Now we start the 11th session of the Mega online course. First, I would like to start and introduce Dr. Mona Mubarak, consultant anesthetist and chronic pain management in Ireland and UK. Dr. Mona was working in Birmingham University till December 19, fellowship in chronic pain from Australia, and neuromodulation fellowship from St. James Hospital in Leeds. Special interest in pelvic and cancer pain. Please welcome Dr. Mona Mubarak.
How are you? Thank you very much for inviting me. It's a pleasure to give this talk. So thank you very much for giving me this opportunity today to speak about complex regional pain syndrome. This is the topic of the lecture today. This syndrome actually is one of the most difficult problems to treat in chronic pain management. And this is because it is either underdiagnosed and left neglected for years and years before patients has been referred to a chronic pain consultant. And when it is diagnosed, it's actually ending up with a complete disability to the patient. So I worked in a center in Australia in Sydney Teaching University Hospitals, which is Royal Prince Alfred Hospital, and this is one of the centers that is specialized in this kind of treatment. So I believe this topic is important for all anesthetists because you might not see these patients in chronic pain management, but you might see them in the preoperative assessment clinic or in a follow-up after the operation, which is usually an orthopedic surgery. And I believe that if I highlight the problems, then you will have a very good idea to start referring the patients, or at least to start managing these patients in the clinic. So what is complex regional pain syndrome? It is in fact a disorder of a body region, usually affects upper or lower limbs. It begins following a fracture, a soft tissue injury, or indeed surgery. So it describes an array of painful conditions, either spontaneous or evoked, and these that is seemingly disproportionate in time, degree to the usual course of any known trauma. By this I mean that usually anyone who has an orthopedic fracture or surgery, or even a normal surgery, usually they recover completely within a 3 months period. Most of them will recover from the pain within 2 weeks after the operation. But in CRPS syndrome, we will find that all these normal progress of any event is disproportionate in time and the degree to the inciting event. So it is not in a specific territory or dermatome. This is one of the criteria that you will actually find. You will see the patient and see what is this, what's going on. Once this flag in your head, you need to think about the complex regional pain syndrome. So it is not in a specific territory. It shows variable progression over time as well. And see what is this, what's going on. Once this flag in your head, think about there's some echo in the sound. Are you hearing me okay? If there is any problem. So there are historically some alternative names to CRPS syndrome. This is it was called previously reflex algodystrophy, causalgia, psoriatic atrophy, transient fibrosis, and acute atrophy of the bone. Also, the upper extremity is usually involved with following a stroke, myocardial infarction, and this was sometimes referred to as the shoulder-hand syndrome, Of course, the term CRPS syndrome was not actually recognized in the past, and that's why the link between myocardial and or stroke, because the pain usually in the hand or in the shoulder, and they made this terminology as a shoulder-hand syndrome. So I'm going to talk a little bit about history, and this is regarding CRPS, which initially considered in it was seen that soldiers suffered from low velocity mass missile injuries developed a pain termed pusalgia. In the 1940s, the term reflex sympathetic dystrophy came into the relating to the belief of an abnormal efferent reflex from the sympathetic nervous system. I'm going to come back regarding the sympathetic nervous system. It has a very important role indeed in the CRPS syndrome. CRPS syndrome is a rare disease, but started to be overly diagnosed, and I'm going to come to this back again as well. So, regarding the pathophysiology, there is a great deal of frustration in the pathophysiology because, in fact, it's unknown pathophysiology. CRPS syndrome is determined by the post-traumatic inflammatory reaction. So it's mostly inflammatory process by the activation of the innate and adaptive immune system. It's from the A to Z, it is an innate immune system that causes these troubles. Without adequate treatment, there will be central nociceptive sensitization, reorganization in the cortex in the brain, and implicit learning processes that develop, whereas the inflammation moderates all these changes in the body. So now I move to the next slide. Please stop me if you can't see. Pathogenesis. There is a significant increases in the pro-inflammatory cytokines, and I'm talking specifically about interleukin 1 and 2 and 6 and tumor necrosis factor alpha. These are the main targets in the CRPS syndrome. There is also release of the inflammatory mediators and pain-producing peptides by the peripheral nerves. So as you see, there is actually central mechanism, which is a central sensitization at the level of the spinal cord and the brain, which is a CNS. And there is peripheral inflammatory reaction as well, where the nerves, the peripheral nerves, will release the interleukins, which I have mentioned before. There is as well some neuropeptides that can produce pain, and the signs of inflammation include substance P, neuropeptide Y, and calcitonin gene-related peptide. This process is known as neurogenic inflammation. So this is the whole pathophysiology of the CRPS syndrome. If we are able to stop this at any stage during the treatment, then we will probably achieve success in the treatment. Regarding the incidence of this syndrome, incidence is between, in fact, 5 and 26 per 100,000 per year. The CRPS is more common, unfortunately, in women more than men, and the ratio is 2:1 to 4:1. There is inciting events always, and this is to diagnose a CRPS syndrome. So there is the most common inciting event leading to this syndrome are fractures, crush injuries, sprains, and general surgeries in general. However, there is no precipitating factors that are identified in up to 10% of the patients. So you might find some patients coming to the clinic have a full-blown picture of CRPS syndrome, but in fact, there is no history of any precipitating events. In fact, if you ask about some psychological events or trauma, you might find this patient has been exposed to a significant psychological trauma, and this is only can precipitate CRPS syndrome in some of the patients and up to 10%. In a large retrospective control cohort of 1,043 patients with CRPS syndrome at a single central referral clinic, the most common inciting events were fractures, 44%, blunt trauma injuries, including sprains, and this is 21%, surgery, 12%, and carpal tunnel syndrome, 7%. So if the surgery, even very small, such as carpal tunnel syndrome, it can actually precipitate CRPS syndrome. Now I'm going to speak about the diagnostic criteria of CRPS. And in fact, I spoke about it is overly diagnosed sometimes and underly diagnosed sometimes. Mostly it is overly diagnosed. And why? Because there was no specific criteria for CRPS. It was mostly subjective, which is depending on the patient description rather than the presentation of signs and symptoms that we can rely on. So the modified Budapest criteria came into effect, and it specifies that the patient has continuous pain, which is disproportionate to the inciting events. Remember this word, please. It should be disproportionate. The patient has at least one sign in 2 or more of the categories. I'm going to speak about this now. Also, the patient has at least one symptom in 3 or more of the categories, and there is no other diagnosis can better explain the signs and symptoms. And by this, I mean, sometimes the patient might have say peripheral vascular disease, such as Raynaud's syndrome or any vascular abnormality or DVT. This, of course, will lead into swollen feet or leg, all inflammatory signs. So we cannot say this is CRPS syndrome. We need to exclude other causes, which is a differential diagnosis, before we diagnose CRPS. And when we exclude everything and nothing else can justify, then we can put the term CRPS syndrome. Regarding the signs and symptoms that I have mentioned, it's actually 4 categories. Sensory, which is allodynia. Allodynia means the normal touch, which is normally doesn't cause pain. It will cause pain actually in CRPS syndrome. There is hyperalgesia as well, which is increased sensitivity to normal pinpricks, which is normally not very painful. And there is hyperaesthesia as well. And all of these coming into effect in 69% of the patients. Motor trophic changes in the form of muscle wasting in the area, because the patient doesn't use the area so much because of the pain. Myoclonus, jerking, rigidity of the affected limb with contractures, nail and hair trophic changes. And you can see this actually in the either upper or lower limb. There is vasomotor changes as well, such as temperature and skin discoloration. You will find that the skin either very cold or very hot, and usually the skin temperature change is within 1 degree centigrade. And the discoloration, it could be blue or red, and you can see the difference very well compared to the other side. Pseudomotor changes in the form of asymmetric edema and abnormal sweating. Usually these patients are very sweaty in the hands or feet, and you will find the edema as well. Now, I'm going to speak a little bit about evidence-based medicine. There is a Cochrane review done between 2013 and 16 to discuss these issues, and the 400 studies in total were reviewed. They looked at the combined local anesthetic, steroid treatment, ultrasound guided blocks, intravenous regional anesthesia, pulsed radio frequency treatment, and different treatments for CRPS syndrome. From the existing evidence, it's not possible, in fact, to draw firm conclusions regarding the efficacy or safety of any intervention for the treatment. But the limited data available do not suggest that local anesthetic selective nerve root blocks is effective for reducing pain in CRPS syndrome. Regarding the symptoms, as I mentioned, the symptoms are usually pain, sensory changes, so the patient might feel numbness, pins and needles, or we call it paresthesia. He might have motor symptoms such as the limb is weak, motor power is less, there is autonomic dysfunction, and this is in the form of sweating or temperature changes, as I mentioned, or trophic changes. So you will find the affected limbs has no hair or the nail is falling off. These develop after limb trauma and usually within 4 to 6 weeks after the inciting event. Symptoms are no longer fully explained by the initial trauma, because of course we cannot explain why a simple orthopedic or radial fracture, for example, will end up with these significant changes in the limb. Symptoms affect the distal limb, go beyond the region involved in the trauma. This is very important. So as I mentioned, it does not limit itself to a territory or a dermatome of a specific nerve, or extend beyond the territory or innervated by a single nerve or nerve root. Regarding the diagnosis, modified Budapest criteria are the gold standard, but in fact, there is no specific gold standard test or method to confirm the diagnosis. It's merely dependent on the physician who sees the patient. Some investigators assert that certain investigations are useful for the diagnosis of CRPS syndrome, particularly the 3-phase bone scintigraphy, showing increased radio tracer uptake in the joint distant from the trauma site. Other tests with some possible utility include side-by-side radiographs. Of course, we need both hands to be done on the same radiograph, and we can see spotty bone decalcification. Long-term or repetitive skin temperature measurements, but this is in fact for academic use. I never ever used in my clinics. But if I put my hand on both sides of the affected limbs, I will definitely feel the difference in temperature. It can be very cold, it can be very hot. Now, also there is some autonomic testing. Autonomic tests that have been used to evaluate the patients with suspected CRPS include the resting sweat output, the resting skin temperature, and the quantitative pseudomotor axon reflex test. Again, these all for academic and research work, but not in clinical practice. Other tests and interventions, there is no clear role for MRI or CT scan in the evaluation of these problems, nor is there is any role as well for the response to sympatholysis to confirm the diagnosis of CRPS. I mean by this, some patients, some physicians prefer to do lumbar sympathetic blocks or guanethidine intravenous regional blocks to see the response, but this is not actually of diagnostic value at all. MRI may be used to exclude some conditions in differential diagnosis, but it's not useful for confirmation of the CRPS syndrome. Now, let's move to the huge category, which is a differential diagnosis. It's really important that any physician, or I mean the pain physician, when he sees the patient, to have in his head all the possible other causes, exclude them. It's a teamwork. I need to refer the patients maybe to my vascular colleague or to my neurosurgical colleague, or rheumatology colleague to exclude the other causes if I, by history and by basic investigations, I suspect something else. So the differential diagnosis include the infection of the skin, muscle, joint, bone, which is characterized by redness, erythema, edema, warm skin, and pain. Compartment syndrome is one of the most important factors to diagnostic things to exclude as well. Peripheral vascular disease, which leads to hyperperfusion of the feet and legs, and this is resulting in a cold feet with discoloration, leg cramps, or pain that is worse with activity and better with rest. DVT, peripheral neuropathy, vascular thoracic outlet syndrome, and of course this is because if you have a cervical rib or something, you will have really a decreased pulse in that hand, you will have a swollen hand, you'll have all the similar pictures. And by the way, I have seen so many patients and they have thoracic outlet syndrome, so I have referred them, and by surgery, actually the whole situation has been resolved of the upper limbs. So I always say the pain physician is like the FBI detector. I have to investigate and find out exactly what is the reason of this pain. History taking is very important. An iceberg of knowledge on the top of iceberg. So the top is very small, but the bottom is very, very big. Raynaud's syndrome is one of the other things to exclude. Erythromelalgia, I put this actually to make everyone aware. Most of the anesthetists may not be aware of this syndrome. It is a congenital or hereditary syndrome. It is actually a clinical syndrome characterized by intermittent occurrence of red, hot, painful extremities. So it's a very, very similar to a CRPS, but it's not CRPS. Management is completely different. The syndrome usually affects the legs. Here are some few pictures. You can see the difference in the hand, in the feet between the CRPS. It causes significant functional disability. The limb is completely lost, like the patient cannot walk, cannot use the hand, completely disabled. Why this syndrome become overly diagnosed? For few reasons. Symptoms are subjective, as I mentioned, so I completely depend on the patient. If he say my pain on numerical rating scale score is 12 over 10, of course there is nothing called 12 over 10, but they are overly, describe the pain because of the severity. It's subjective. I cannot say to him, no, it's not. So I need to listen, and at the same time I test and find out if these are true symptoms or not. The discovery by personal injury lawyers who use it as a tool for settlement, this item is mostly existing in England and in Ireland, but in England and Australia actually so much. So if anyone has a hit by a car or any work-related accident, they actually claim they have CRPS syndrome. The lawyers who sue the institutes are very well aware of this. They use this terminology to get the compensations. I don't think this is very common in Egypt, but it is common in the Western community and world. Patients self-research on the internet, and again, patients come to the clinic and say, oh, I have CRPS syndrome, and then I have to either agree or disagree with him. There are two types. Type 1, the majority of the patients who have type 1, and it's less painful and it's less debilitating of the two. Type 2, it is related to a specific nerve injury with neuropathic pain. It's thought that to be pathological and not psychopathological in origin. Now, moving to treatment. In Pain Journal 2017, pharmacological treatment may be particularly effective in the acute stages, and this includes specifically steroids. So bisphosphonates as well can be used, and DMSO. Common anti-neuropathic agents that such as pregabalin, gabapentin, and tricyclic antidepressants are intravenous long-acting, long-term ketamine infusion, and this shown some efficacy in the randomized controlled trials, but it is repeated application is demanding and has side effects. Important components of treatment include physiotherapy and occupational therapy. Medical interventions include, actually, it has a low quality of evidence, as I mentioned, but we have to try it anyway because we won't lose anything. The patient already lost his function. We need to do everything possible to try and help the patient. The bisphosphonates, calcitonin, or daily course of IV ketamine can be effective for pain when compared to placebo. Graded motor imagery can be effective as well, and this is mainly through the physiotherapy, and it is improving the function compared with the usual care. Mirror therapy, mirror box therapy, it's available on the internet. If the physio cannot offer it, the patient can try it himself. It's very easy, and it's effective for pain in the post-stroke CRPS syndrome compared to the covered mirror control. Also, there is low quality evidence for physiotherapy or occupational therapy, and these are associated with a small positive effects and are unlikely to be clinically significant. Oral calcitonin, N-methyl D-aspartate antagonist, clonidine, and bisphosphonates can be tried. Topical pharmacotherapy such as patches and capsaicin. Capsaicin is a patch 8%, and this is capsaicin cream as well. So I start with the cream, and then I bring the patient for the patch in the hospital. Psychological therapies, operant conditioning, CBT treatment can be used as well. There is this. Now I'm going to present quickly the results of the European Pain Federation Task Force in 2000. This published 2019 April. A very recent one about this problem. So they have recommended specialized care facilities must provide advanced treatment for CRPS, including multidisciplinary, psychologically informed, rehabilitated pain management program. And I have to add here, it's not, from my experience, not only multidisciplinary, it's in fact interdisciplinary. This terminology is very important, and it is actually a higher degree of multidisciplinary care treatment. Referral to super specialized center must be initiated for a small number of patients with complications such as CRPS spread. And this, I mean, the CRPS not only affecting one limb, you might find this affect the whole body or 4 limbs or whatever. So the patient can completely become incapacitated. Fixed dystonia, myoclonus, and severe psychological stress. Referral to a specialized care must be initiated for those patients who do not have clearly reducing pain and improving function within 2 months of commencing treatment of their CRPS syndrome. This is another Cochrane database review 2013 continuation, and it talks about medications aiming at pain relief but may not be effective in CRPS. Stopping rules should be anticipated or applied, which means if we start steroids in acute CRPS syndrome, and usually I start this starting as 30 milligram daily and decrease by 5 milligram every 3 days for 3 weeks in acute CRPS syndrome. Unfortunately, I have seen so many patients who present to the clinic after 3 years treatment with CRPS, either in GP practice or in a general physician practice. They are on high amount of bisphosphonates, steroids with the full-blown picture of steroid side effects. There is no stopping plan. We always need to have stopping rules. If we make a drug trial, any drug trial, we have to make a window where we are going to stop or decrease this gradually. Medications include NSAIDs, NMDA antagonists, and this is such as ketamine, there is oral, there is IV, opioids, calcitonin, and alendronate. Lumbar sympathectomy, such as stellate ganglion block for upper limb problems, peripheral nerve blocks, pulsed radiofrequency ablation, epidural clonidine, and botulinum toxin A. And botulinum toxin A actually had a very good results, and this was published in the Lancet 2015 for neuropathic element of pain. Here are some pictures. The first one is showing the lumbar sympathetic injection, and you can see the dye in front of the vertebral body, and this is exactly the place where we want to go. Then there is 2 pictures. The bottom one actually is showing the radiofrequency ablation needle in the AP view, and the last 2 pictures again is talking about the lumbar sympathetic injections, and actually sometimes they do lumbar sympathetic neurolysis by phenol, but I have never did this, and I found actually this is a very aggressive way of treatment, but when the patient reaches to the stage and say, I want to amputate my limb, maybe he's willing to lose some of the functions of the bladder or the lower limb to avoid the amputation, but I do not recommend actually this type of treatment. This is the form of stellate ganglion block, and of course it's at the C6 level, and as you can see, it can be done blindly, which again, something I never recommend. Usually we do it under X-ray, as you see, or with ultrasound. The aim of this treatment, orally administered pharmacological options aim to target and alter physiological pathway involvement in the generation of pain, inflammation, abnormal sympathetic activity, or bone loss. So this is our aim. Sympathectomy, because the sympathetic nervous system has a very big role in CRPS pathophysiology. It's aimed to reduce the sympathetic neural activity to temporarily or permanently disrupting the sympathetic nervous system. Neuromodulation approaches, and this is such as spinal cord or brain stimulation techniques, deep brain stimulation techniques. Again, I never saw it. I just saw maybe some lecturers or professors speaking about it in the US, but I don't think it has a very big benefit here. Spinal cord stimulation is one of the very important and actually one of the gold standard way of treatment in CRPS, and I have used this significantly in Leeds Teaching University when I was doing the fellowship there in neuromodulation. The psychological therapies primarily aim to improve the function and the disability rather than the pain, because patients will have a fixed idea. They will have such as pain, fear to move, because fear can cause pain, but actually fear to move will make more disability, because if they don't move, they will get the contractions. So these fixed, abnormal, or pathological ideas need to be changed through the CBT or the psychological treatment. So regarding the neuromodulation, quickly, I will touch base. Novel spinal cord stimulation methods include burst stimulation, high-frequency stimulation, and dorsal root ganglion spinal cord stimulation. And this provided the clinician with multiple options to treat refractory chronic pain in CRPS syndrome. This is a very big topic. I've seen myself big number of patients, and actually burst stimulation was the best to give results in my experience. Amputations in CRPS can be considered, and this is indicated due to severe pain, limb dysfunction, gangrene, infection, or ulcers. The majority of patients report a reduction in pain along with improvement in mobility and sleep following amputation of the affected limb. But many suffer from phantom pain and recurrence of the residual pain, and this is another problem. If the patient comes to me seeking advice regarding amputation, I advise completely against it, and I explain the possibility of having phantom pain, phantom limb, and stump pain. This is another big topic, but unfortunately, the surgeons always say, okay, and go ahead. But when they come to me, I stop. And I say, no, this is completely, we can treat, we can help, we can do something. So I'm very positive when they come to the clinic, and I'm trying to avoid this as much as I can. Now I'm going to give you a quick case report, an occupational health report, and this is one of my patients who presented to the clinic when I was working in Dorset University NHS Trust last year. And this patient is 36 years old, and actually she is working in the police. She is working in the prison, and the police in the UK asked me to make an occupational report for her to assess her suitability to come to work, and asked me to conduct her treatment in an expedited manner, because the NHS waiting list is usually very long. So she is 36 years female with a CRPS, and this actually, it was since June 2018. She's a police officer, had a work-related accident, and when she was saving lives. While she was recovering from, she had 2 accidents. So when she was recovering from the first accident, she was exposed to, unfortunately, another accident in the prison, and was left with post-traumatic stress disorders, because the prisoner actually was killed, and she could not save that person on time. So she was left by the guilt sensation, and psychological trauma, as I mentioned, has a huge impact, but she had as well some physical impact by the prisoners at that time. She presented to me in the clinic in May 2019 with a full-blown picture of CRPS syndrome. Psychological treatment for PTSD was done. So we have in the team some psychological colleagues who actually specialized in PTSD treatment. Some of them are specialized in CBT treatment. So I have referred to the specific specialty that will help this lady. Multidisciplinary approach involved occupational therapy, and this is very important in the treatment, because in fact, she was off work. When she returned to work, the occupational therapist will assess the workplace. They will say, adjust her office, her sitting position, what type of work she can do. They will look at her house. Does she need any adjustment in her shower, rail? Does she need a step? Can she go upstairs in her house, second floor or not? So the occupational therapist is very important in the treatment process. There is as well specialized pain nurse who give her pain management program, psychology and physiotherapy involved. There was an urgent alert that time was raised by me to expedite the treatment for this lady and to skip the waiting list, because the more we stay with the CRPS syndrome, the more the disability and prolonged discomfort. So I have started with this lady a tricyclic antidepressant, antineuropathic agent, and SNRI, which is selective noradrenaline reuptake inhibitors. I have actually performed right popliteal cytic ultrasound guided nerve block in the hospital with a steroid in July 2019. Her pain was mainly in the right foot and leg. Follow-up was done in September 19. Surprisingly, when she came in the clinic, she left the crutches. So first time when she came, she was using the crutches because she was not able to walk at all on her leg. After the injection, she has achieved 70% relief of the pain. However, she could not return to work yet because of the weakness in that area. And of course,
we are running behind the time, so we'll give you a few more minutes.
Yeah, sure.
Thank you.
probably the last October 19, gradual return to work. November 19, sympathetic block was done, and December 19, there was significant block improvement, 90%. That's all, and thank you very much, and sorry for the long presentation.
We are going to take the question right now in between the two lectures.
First question is from Michael Awad. He is asking, are there any predictors that can foretell the development of CRPS?
Well, there is no actually predictors. Historically, they thought that if there is a psychological trauma or the patient has history of psychiatric illness that's such as depression, anxiety, or PTSD, this is predisposing factors. But the future research or review said that there is no predisposing factors. Only thing that in female it's more common than in males, but we will be highly suspicious if we know that the patient has actually pain for more than 3 months after any inciting event, and again highly suspicious if the inciting event was very small or negligible. So no specific actually predisposing factors, can happen to anyone anywhere.
Okay, after thanks from Dr. Ain Abogali, asking, is there any prophylactic treatment that can be used to prevent CRPS? And is there any difference in treatment in CRPS 1 and 2?
So I believe the first question is asking about if there is any treatment that can help with this syndrome. I would say no. It is one of the most difficult and complex, problems to treat. The treatment is completely empiric. So we start with conservative treatment, and then we move up in the ladder. Of course, we start with the simple stuff, which is normally non-steroidal, and then go to the weak opioids, then strong opioids. We need to add a to attack the problem from multiple angles. So use, say, opioids plus anti-neuropathic agents plus tricyclic antidepressants. So combined treatment, 2 or 3 things at the same time. But if you talk about evidence, no, there is no evidence about any specific treatment that is successful. I believe calcitonin is one of the things that is shown some efficacy. Steroids in the acute CRPS and not in the chronic one shown some efficacy. Then we speak about the injections, and again, there is no gold standard.
Another question from Dr. Ain Abogali, is there any difference in treatment during stages of CRPS?
No, actually, we have classification acute or chronic. I believe in acute one, it's a comfort is the main thing to relieve the pain. So painkillers and to start with the simple stuff, steroids as well. But in chronic, no, there is no specific actually thing, because we don't have actually grades like simple and complex CRPS. Once the CRPS is diagnosed, it's a full-blown picture, and the treatment is a standard.
Yes, sir. There are a question from Dr. Ahmed Ibrahim. No more causalgia and the symptomatic dystrophy names. This was the question for Dr. Mona.
Yeah, so no, actually, these names are gone now from the medical field. It's only what initially described the CRPS syndrome, because they divided it into type 1 and type 2. So type 1 was called causalgia and type 2 was called sympathetic dystrophy. But nowadays it's CRPS that describe both of them. And then we divide into type 1 where there is no nerve injury, and type 2 where there is nerve injury.
Another question from Dr. Hani Bayoumi. Is there any criteria or score to change from medical to interventional management, or only depends on patient level of pain and response?
Okay, very good question. It all depends on the clinical sense and the judgment. Usually, when the patients present to the pain clinic, already there is already a big lapse of time. Usually they come to me or the pain clinic after perhaps more than 1 year. The average is about 3 years. So, but at this stage, already all conservative management has been trialed. Patient already has tried most of the medications. They had already physiotherapy done. So once they come to the pain clinic, we need to be more aggressive. So we start, there is no guidelines especially to do what, but always combined therapy is highly recommended, especially to combine 2 antineuropathic agents. So we do combine treatments, and actually we might combine as well interventions. So we can try 1 injection, but what I don't do usually is to avoid always the combination of 2 injections in the same time. So we cannot actually offer the patient, say, a peripheral nerve root block and say sympathetic or stellate in the same time, simply because the results will be completely mixed. So we won't know either the first treatment did cause benefit or the second treatment. And if 1 treatment did cause a big benefit, we can escalate this by doing pulsed radio frequency or radio frequency ablation. So we need exactly really to know what is the effective treatment. And that's why my recommendation, medically, you can try any combination, no problem. But intervention-wise, we need to do 1 thing at a time and then proceed.
Another question from Dr. Ain Aboghali. Is there any investigation help in prognosis?
Okay. In fact, no. But there is a common, sense, or we know from the literature that the cold CRPS prognosis is much worse than the warm CRPS. So if the patient is presenting with a very cold peripheral, limbs like hands or feet, the prognosis here is more bad. And it's usually a late stage, which means that the patient already has passed through the initial vasodilatation, which is a warm stage, and then now they are at the vasoconstriction, which is the cold stage. So the cold is more detrimental in the treatment or in the prognosis compared to the warm one. But as I mentioned, there is no specific or single investigation is a gold standard or can give us any idea about what is this syndrome and what is the prognostic factors. The early presentation, the early management always has a better prognosis.
Okay, thank you. Before we end, I like to promise our colleagues and our attendee, as noticed by all, that the voice is not completely clear for this precious lecture for Dr. Mohammed Shourbagi. We promise to record this lecture and put it on our YouTube channel as soon as we manage the problem. Thank you for all.
Thank you very much. Thank you very much, everybody. Thank you.
Thank you
very much.
Thank you.
Have a nice day. Nice weekend.
Thank you.
Thank you.
Thank you.